The world is failing its newborns. That's the warning today from UNICEF in a report that says the death of babies globally is alarmingly high. So, can child mortality be reduced? And if so, how? This is Inside Story. Hello again, welcome to the programme. I'm Peter Dobby. At least 7,000 infants die every day, mostly from preventable causes. That's according to a report by UNICEF that found babies born in some of the poorest countries are significantly more likely to die. Countries such as Pakistan, Somalia, Central African Republic, Afghanistan and Lesotho have the highest rates of newborn deaths. We'll examine the reasons with our guests in a moment, but first this report from Imtiaz Tayyab.
This is one of the busiest maternity wards in the Pakistani capital, Islamabad. Several babies are born here every day, but the odds of survival for infants across Pakistan is some of the worst in the world. According to the UN's children's charity UNICEF, 1 in 22 die within their first month of life.
The mothers don't have access to the hospitals, they don't have access to the trained birth attendants, the mothers are malnourished, they are anemic, and there is a lack of awareness among the masses to take a mother to the hospital or a healthcare provider at the time of the delivery.
The situation globally isn't much better. Every year, more than 2.5 million babies die before turning 1 month old. 1 million of them take their first and last breaths on the day they are born. Another 2.6 million are stillborn. Central African Republic, Afghanistan, Somalia, and Lesotho round out the top 5 nations where infants struggle to stay alive. There has been some success in reducing child deaths. The number dying before their 5th birthday has halved over the past 25 years, but according to the UN, millions more could be saved if mothers and babies have access to affordable quality healthcare, good nutrition, and clean water.
Some of the governments actually that are worst off spend less than 1% of the gross domestic product on healthcare, and the national recommendation is to spend at least 5%. If you couple that with training competent health workers, giving them a chance to wash their hands as they step in to deliver babies, and having basic equipment, drugs, getting breastfeeding going within an hour and sending girls to school, I think it's within reach of all governments to do that.
Babies born in countries across sub-Saharan Africa often face the toughest odds. That's mainly because pregnant women are less likely to receive assistance during delivery. Imtiaz Tayyab, Al Jazeera.
Okay, let's get going. Let's bring in our guests in Karachi, Dr. Shersa Siad, founder of the Pakistan National Forum on Women's Health, and in New York, also on Skype, Dr. Willibald Zek, head of UNICEF's Global Maternal and Child Health Programme. Welcome to Inside Story. Shersa Siad first. Why is this figure in Pakistan so very high?
Well, unfortunately, in Pakistan, the very high rate of poverty, illiteracy, and the government's failure to provide basic health care is the main reason that we have all this higher mortality in every area.
Willibald Zek, in New York, how many of these deaths are actually preventable?
Yes, I think that there is quite a substantial number of deaths preventable among newborn deaths. And it is simple interventions that can make a difference, although we have many newborns that might need sophisticated care. But what we have estimated in our report, if globally every country would do the major effort that is needed, then we could save 16 million newborns by 2030.
Shersa Siad, in Karachi, this is not explicitly linked in Pakistan to income level. Are there other factors that we need to be aware of as well?
Well, I mean, if you know that in Pakistan we have more than 50% of the population living below poverty level. Yesterday I was operating in one small hospital just 60 miles away from Karachi in KT Bandar, and 14 patients I operated, all of them are having hemoglobin less than about 9, and they are all malnourished. But we have to operate them because they're all having prolapsed uterus because of the multiple pregnancies, and they have these multiple pregnancies because of the very high neonatal mortality rate. So it's all interlinked. But the main thing is that if you are poor, you are going to have all this problem. Poverty is the biggest curse which we are suffering from, and especially the majority of our population. And it's the women who are the main sufferer. And if the woman is poor and she is not able to provide anything to her children, then that's the way it happened.
Dr. Sek, if you're born in Singapore, Iceland or Japan, chances are you'll do very well in those first crucially important few days of life. What is it those countries are doing right that other countries might learn from?
It is absolutely true that there is more funding available. And of course, these are high-income countries with different fund budgets, and the poverty levels are lower. But I think there are things and intervention that we can learn from. First of all, for sure, the policy on the political commitment that we have in those countries. And then also on a very decentralized district and hospital level. Japan has, for instance, introduced a mother-newborn health book, which is basically a track record of how the mother and the newborn is doing during pregnancy, during childbirth, and a postnatal period. And then, of course, it is also the quality of care that is a very big concern that has been addressed in those countries. And I think also here we can learn, because we know that, if the quality is good of a certain health service, then women will come back and also bring their newborns back. So if the quality is poor, or if there's not enough supplies in a hospital, for instance, because of stockouts, then women will not come back. And so this is it's a vicious cycle, actually.
OK, political commitment, that sounds like shorthand for making sure that presidents and prime ministers, that home secretaries, home ministers do what they should be doing when it comes to healthcare. How do you see that role of those individual people changing? Because presumably it needs to be driven by an individual.
I think it is not only on national level. It's also very important that the political commitment is there on district level or on a province level. So it's really throughout the whole system. And I think the commitment is there in many countries. And what we also see is that some countries, especially those who are stepping up into middle income status nowadays, that there is more funding available. But what we also see is that funding alone doesn't make the difference. It's not about the money only. It's also to put the money smart. And also, as we heard just now before, it is empowerment of women. We know that educated women, or women who are educated and who are empowered, have or face lower mortality rates within their own population, but also for newborns. So it's a multi-layer problem, but certainly poverty is the underlying issue, of course. But it's also about how to put funding in a smart way and invest it in a smart way with political will.
Understood. Dr. Syed in Karachi, we could also turn these figures from UNICEF around and say they're actually good news, in as much as the mortality rate for newborns is down by 49%. But the mortality rate for newborns up to 5 years old, there's been even more progress there. Are they caused by the same factors? Are the issues and the problems the same for newborns as for those little children up to being 5 years old?
Well, I mean, before I answer this question, I just want to mention one more thing. The countries you mentioned, like Japan or Iceland, remember one thing, all these countries has empowered women. Women's status is very important. In our countries, especially Pakistan, woman has no value in the society, and if the woman has no value in the society, then we don't want to save the woman. Most of the women just dying during pregnancy as a maternal death, and when a woman and a girl child doesn't matter, then how you can prevent neonate when a woman is coming in the hospital with the hemoglobin of 4 or 5 and 6? That's the routine. So come back to this figure in Pakistan. I mean, compared to Japan, where 1 in 11,000 babies are dying, in Pakistan 1 in 22 baby is dying. So that's too much. And as it is mentioned, that it is the poverty which has the main reasons for this death of the neonates.
Dr. Zek, are some of the solutions to this particular huge problem quite old-fashioned, reassuringly old-fashioned, I guess? It comes down to skin-to-skin contact between mother and baby within the first 60 minutes of life, literally, and also breastfeeding. So that bond is made, so the immunity system of the child is improved from the get-go. And that doesn't cost anything. That's free medical care, if you will, at point of delivery.
Absolutely. And so it's really simple interventions that are the first line. They are not a magic silver bullet point, bullet, but they are very important interventions that can help at least a big proportion of the newborns to survive. It is about skin to skin, which means the baby is put on the tummy of the mother when it is born and breastfeeding is started, and the cloth should be wrapped around the baby so it's being kept warm. What we see in some countries is that there are some misbeliefs or some misbehaviors, if you want, that newborns are being fed with coffee or with water sometimes. And there it is very important that we, again, empower women and educate them what to do and how to deal with those newborns and what to do with them. And that's why we also believe that postnatal care, which means the care after delivery for the newborn, even at home or at the hospital, wherever the newborn is staying with the mother, is crucial, so that the newborn can survive. But we also have to see that we have sophisticated cases, where very complicated cases where these very simple interventions do not work, and we need simply more. One example is, for instance, babies that are born too soon. We call them premature babies.
Dr. Syed, in Karachi, you're talking about empowering women and educating women. Is it also about educating the whole family, particularly the male figures, the father figures, literally, within the family unit, adopting a holistic attitude? Because it occurs to me some of these countries, maybe the men folk have a very distinct attitude towards women and childbirth, and that's something that women and childbirth, they do that on their own. The men maybe don't get involved in that. But if the men did get involved in that more, there would be that would inculcate a healthier atmosphere surrounding the whole process.
Well, you are 100% right that it is important to educate every member of the family. But in our experience, we are in a big way, we are training midwives in Pakistan. And we feel that when you educate a woman, a girl in the house, she will take care of all the younger brothers and sisters. But if you educate a man is not going to give that kind of input what an educated girl does. So I think in Pakistan or any country like Pakistan, it's very important to educate girl child and the woman. It is more important to educate them than the boys in the family. And we have seen in the family when like a poor population like Orangi and Korangi and Chambla Basti and Landi, these places, when you educate a girl child, she is really good for the whole family. So I think if there is limited resources and money has to go somewhere, I will go for the education of the girl child and the woman.
Well, we always talk about children dying in poor countries
empowerment.
because of poverty and a lack of well-trained health workers. But what's the situation like in the developed world? Well, take Norway, for example, where for every 667 children who are born, one of them will die, while in low-income countries, that figure is nearly 10 times higher. In Cyprus, the situation is even better, with just one death for 714 infants being born. But in Japan, as we've been hearing, newborns have the best chance of survival any place in the world. There's just one death for nearly 1,200 births. Let's take it back to Dr. Williband Zek in New York. Just looking at the bigger picture for us, one would assume, say, an incredibly prosperous country like the United States would be in the top 10. It comes in at 41st, so it's not doing very well. So that's questions of healthcare at point of delivery, health insurance, I guess, might be an issue there, and also income inequality across the country. And yet, if we go to another country like, say, Rwanda, they've done very well, despite being associated with conflict and poverty over the past, 15 or 20 years. But how has Rwanda done it and managed to cut its figures so dramatically?
Yes. We saw what we see in the report is that very big countries like the US can feature very huge equity gaps. And if you have equity gaps, that means that you have populations that have not the best access to health services. And these pockets of inequity will then, contribute to the overall picture. And that's why we see a lot of, higher numbers in big countries. I think Rwanda is a very good example of how a smaller country, of course, if you compare it to United States or other countries, has really achieved a lot. And I think one of the major achievements is, as you said, health insurance and also universal health coverage. Rwanda has really committed to that. And it's also political will, I think, that is showing in Rwanda that, you can make efforts that everyone has access to the health care. But as I said, it's a multi-layer, complicated system. It's about poverty. It's about empowerment of women, the cultural background, and then also whether enough funding is available. And in some countries, we see also in African countries that they are stepping up to middle-income status, and there we have more funding available. And if it's put in a smart way, we can really help to reduce death rates among neonates and mothers.
Dr. Said in Karachi, how easy would it be to take, say, the model of Rwanda, where you've got strong healthcare institutions, and graft that model onto other countries?
Well, I'll give you just one example. In Sindh province, during the previous Chief Minister, Khayyam Ali Shah, they strengthened the PPHI program, Public-Private Health Initiative. This is the program which is initiated to provide basic health care in basic health unit. And you see, the program was not functioning in Karachi and Nawab Shah. And now you can see the difference in Nawab Shah and Karachi. And in Karachi and Nawab Shah, this basic facility is not available for the young woman with pregnancy and the neonatal care. And in other districts, these units are functioning very well because the 24 hours midwifery services are available. And this is just simple comparison you can see, and the difference what happened. So this is the point. If the government emphasize and have the priority to provide the basic health care, the things will change. But in our countries, most of our budgets, they are spending in buying of very, very expensive equipments like robotic system, MRI, and big buildings. And these buildings and these machines are good for the nameplate, but these are not good for the patient. Patient need basic and emergency obstetrical care, basic neonatal care, and you need basic health unit, rural health center, taluka hospital, this kind of thing. And we can see the difference in Sindh as far as PPHI is concerned. And that is the very good model which should be adopted in the whole country. Then there is a chance that we can improve in next 5-6 years.
Dr. Sek, we'll come on to that timescale issue towards the end of our discussion. But if this comes down to weak institutions, conflict either within the country or in countries bordering the country, and also poverty, out of those three main contributory factors, which one is the easiest fix?
Let's put it that way. The most difficult fix, I would say, is conflict. Conflict is really associated, and we have research and evidence around that. Conflict, insecurity is really the main driver for high mortality rates amongst mothers, newborns, and also the population itself, because the population doesn't have access to the healthcare system as it would normally have, and also health workers are scared to go to work. If there is insecurity in their area, they would not go to the hospital for work every day. So I think conflict is a main driver, and I think we really have to acknowledge also that insecurity in those countries who are ranked in the lower part of this report are partly have insecurity issues, and we have to acknowledge that this is certainly a major problem. In terms of other factors, I have experience as an obstetrician and gynecologist in East Africa, and even if there's no insecurities for some women on the African continent, for instance, it takes days sometimes to reach a hospital or a healthcare center. And once they arrive, they're exhausted, and they, of course, sometimes cannot receive the best care because of poverty and because of stockouts of supplies. So I think, what I want to say is that in normal situations, non-conflict, non-insecurity, the situation is already quite alarming or difficult for mothers and newborns.
Dr. Syed, coming to you with
absolutely
that particular point that Dr. Sek was making there, is this just about access to healthcare? You were using the word basic a lot in your last answer. It's not expensive healthcare, it's not MRI machines, it's not state-of-the-art operating theatres, it's the most basic healthcare, but it's caused by not getting access to that healthcare.
Yeah, I mean, you're 100%. What I'm saying, basic means clean water, access to the hand washing, you know, very basic health unit where a trained midwife can provide the basic antenatal care. And then we all know that 90% deliveries will be normal deliveries anyway, and a good skilled midwife can deliver a good baby with a basic neonatal care, with this traditional care of, you know, as you mentioned, touching skin and wrapping with the skin. I mean, these are the basic care, and these things work. I mean, MRI and the big, huge buildings and these things doesn't work. You know, in our country, we have robotic surgical system without clean water and without a trained person, a trained technician. What a mammograph machine will do if female technician is not available. So what I am saying, the very basic thing, activation of the basic health unit, provision of the skilled midwife for the 90% of the women who are going to have normal delivery, and the tertiary and the taluka hospital and district general hospital for doing simple intervention like cesarean section. That will save mother. You know, I mean, these big machines and big buildings and big roads, they don't save mother. It is the right politician with the heart on the right side. They will take care of the woman and the neonates. Unfortunately, we don't have the right politician and the right doctors who have their heart on the right side. So this is the problem.
Dr. Sek, if we go back to the bigger countries for a second, like the United States, or indeed the continent, say, like the European Union, is there a sense in which if they don't have a, quote, national health service, i.e. healthcare that's provided and paid for by some sort of insurance system, that it's kind of a zip code lottery as to whether the baby will survive or not, when you've got that coming together of different factors that influence the delivery of the healthcare?
Yes, I mean, traditionally we have several systems in those continents. As you mentioned, we have the system of Central Asia and Eastern Europe, where we have rather centralized health systems. They are traditionally, you know, where they come from their history, they are very centralized. Some of the other systems in Europe are very decentralized. In the US, of course, we have another system where we have a lot of private sector involvement. But overall, I think we cannot say one system is better than the other. I mean, each system has its pros and cons. What we think is important to emphasize is that we should keep the inequities as low as possible. So the system that will keep the inequities low might be the best, because then we can really talk about universal health coverage, which means everyone should have access to health care, if possible for free, or at least for low cost and with a low out-of-pocket expenditure. This is what we mean by, you know, when someone comes to a hospital, has to pay additionally.
Dr. Syed in Karachi, last point to you, if I may. You've already been talking about a timescale here of 5 years. Obviously, the best scenario would be no infant baby mortality at all. But at what point over the 5 years can you turn around and say, yes, we are making genuine progress in this area?
Well, I mean, it's very simple. If you provide, I will again emphasize, if you provide the basic health care and in the basic health units and rural health center with the skilled midwife and the trained staff to deal with the maternal death and the neonates, you will see the difference. Things will change very fast. I can't tell you the exact time, because I don't know how much our government is interested in doing that. But we have seen in the districts where there is intervention, we see the difference. You know, I mean, and if you want to learn from the countries like Japan and Sweden and Denmark and Norway and England, you see what they have done. I mean, they didn't start doing big things like big building and highways and motorways. What they did, they interlinked the small villages and the counties to the units where the basic healthcare is available.
OK, gentlemen, we will have to leave it there, but for your time, we are very grateful. Thanks to both our guests, Dr. Shersha Syed and Dr. Willibrand Zek, and thank you too for your company over the past half hour. You can see the show again anytime via the website aljazeera.com, and for further discussions, do check out our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter @AJ Inside Story. From me, Peter Dobbie, and everyone on the team here in Doha, thanks for watching. We'll see you soon. Bye-bye.